Okay, I should be able to finish this up in this part 3. Let's talk about the biliary system. Now we're moving into chapter 50 of your textbook. The biliary system basically is going to involve the gallbladder and the pancreas and the bile ducts. So let me see if I can, let me explain this to you, because this is kind of important to know. So here's your liver, here's your pancreas, here's your gallbladder, okay? So the tube coming out of your gallbladder is the cystic duct right here, out of the gallbladder. Then you've got some ducts coming out of the liver, and these are not as important, but the right hepatic, left hepatic, and it comes down in the common hepatic duct. So you've got your main liver duct, your main cystic duct, and then over here you've got your pancreas, which also has the duct coming out of the pancreas, secretes pancreatic juices. And you've got all these ducts coming together to form the common bile duct right here. All of this right here is the common bile duct coming out of the liver. And then where it meets down here in the pancreas, right in here is down in here is called the ampulla of Vater. The most important part is you to know where these pancreatic ducts, the common bile duct, the cystic duct, because, and the reason I'm telling you this is because your gallbladder can develop stones. And then it can see in the diagram, it's even showing you where some stones are here. When you get some stones stuck in here and the bile can't get down, and the whole point of the bile is to break down fat, but it'll start blocking all of this stuff back up, your patient can start getting jaundice. If you get a stone stuck in here, some of the pancreatic juices can get stuck in there, and you can develop jaundice, you can develop pancreatitis, all kinds of other things. So it's really important for you to understand this system. There's another diagnostic tool called an ERCP. Yeah, I think they mentioned it in your book. It's called, let me see if I can remember this, an endoscopic. So remember how I told you, like, it's a scope is an endoscopic scope. Your patient will swallow it. It goes down the esophagus, through the stomach, and into the first part of the small intestine. That's your endoscopic. Retrograde, meaning, okay, so here's the tube that comes down like this. Retrograde means there's a little thing on it that then will go back up into the common bile ducts and the pancreatic duct. ERC, I can't remember what the C and the P stand for. I can't remember. But an ERCP is used to take little pieces of biopsy. So they can, like, if you suspect that your patient has pancreatic cancer, you think they might have common bile duct cancer malignancy, it's rare, but it happens. You can use an ERCP, it's an endoscope with this little tube on the end of it, like this. It goes back up there and you can get a little biopsy. That's called an ERCP. I'll remember what it is in probably when I'm done with this lecture. So, okay, so let's talk about the gallbladder. Coli, like I said, see this word coli, both of that? Gallbladder, that's what that is. Lithiasis, stones, you should remember that from when we talked about renal lithiasis, kidney stones. And cholecystitis is an inflammation of the gallbladder. Okay, lots of things can go wrong with the gallbladder. The only purpose of the gallbladder is to hold bile. The liver makes the bile, and through all these little ducts shoves it into the gallbladder until your patient eats fat. Then the body recognizes, oh, there's fat in here. You ate a Big Mac and some French fries. And so the gallbladder squeezes out some bile, kind of squeezes down into the small intestine where the little fat globules are, and starts breaking down fat. When this gets blocked in here with little stones, because you can develop gallbladder stones called cholelithiasis, the patient can start getting jaundice because the bile starts backing up. When the gallbladder is not functioning properly, or if there's stones that are stuck in here. Some things you can do is like, so if your patient starts complaining that they are getting some gnawing pain kind of in the upper gastric area, especially between 3 to 5 hours after they've eaten, because it takes that long, especially if you've got a big old fatty meal, it kind of digests in the stomach and then starts putting little pieces of, you know, partially digested food in here. Well, as soon as it recognizes that there's fat in here, this starts squeezing. So it's usually between 3 to 5 hours after somebody's eaten. So if your patient is complaining of this, start assessing what did they eat. And if they're telling you they had Big Mac, fries, cake, ice cream, you know, fatty stuff, and then it's hurting, probably see if you can switch them to a low-fat diet, because if they're not eating a lot of fat, there's no need for bile. And then that won't squeeze and it won't hurt as much. We do have some medications now for patients who have developed cholelithiasis, but they take a long time. It takes a long time to dissolve those stones. So you got to figure out, does the patient have cholelithiasis? Do they have cholecystitis? So we get an ultrasound. This is an example of an ultrasound of the gallbladder. So the gallbladder is kind of long, sits right up under here under the liver, and you can see this one is just absolutely full of stones. Symptoms, I already told you, it's a painful, gnawing kind of discomfort, especially after a full meal. This is what a gallbladder looks like that's full of stones. And again, they're going to have very similar symptoms to somebody who is not breaking down bilirubin, but the reason here is because the bile is not able to get excreted. It starts backing up into the liver. They're going to have pain, discomfort, clay-colored stools, jaundice-colored skin, lots of pain. The pain could radiate into the back. The urine can get very dark, related to because bile is now being excreted by the kidneys. They can get fever. If it gets enlarged and inflamed enough, you might be able to feel it. Typically, you should not be able to feel the gallbladder. The good news is you can take the gallbladder out. It's pretty easy to take out a gallbladder. Most of the time, if the patient isn't too sick, they can do what we call a lap chole. In the medical world, it's just lap chole, and everybody knows that that means laparoscopic cholecystectomy. Cholecystectomy being the word, gallbladder, well, cholecyst is the whole gallbladder. Ectomy is removal. Cholecystectomy, taking out the gallbladder. Laparoscopically, we're doing it without a major incision. And the way that this works, when we're doing a lap chole on a patient, is you take the patient, you put them in a little bit of Trendelenburg, put them on their head a little bit. The reason is now you're getting those big abdominal organs, the liver, the stomach, you're getting all of that away. You're getting better visualization of the gallbladder. So they're a little bit of Trendelenburg. The other thing that they do, you can see this patient's a little bit bloated. What they do is they pump up the abdominal space with carbon dioxide, and that will stretch the skin away so that the surgeon who's doing this can visualize that gallbladder. So they've got some different pieces of equipment in here. They've got a retracting device, they've got a light, they've got a camera, and they've got a cutter in there. So they go in just with these 4 or sometimes 5 different tools, and they can easily go in there, clip it off right here, and they just pull it right back out all through one small little incision. That's the beauty of doing a laparoscopic procedure. A couple things we watch for our patients who've had a lap chole. You can injure the bile ducts because, like I showed you, these bile ducts are kind of heading up into here. You got a bunch of bile ducts in here. You can injure those. Sometimes that happens. The big thing that your patients are going to complain a lot about is gas and bloating afterwards, because you've just pumped the whole tummy full of carbon dioxide, and the problem is the patient's on their head, Trendelenburg. So what happens afterwards is all of this carbon dioxide now is going to float upstream, and oftentimes it will get trapped up in the shoulders, and the abdominal or the thoracic space. And the next day after this procedure, the patient will often complain more of pain up in their shoulders than pain in any one of these incision sites. One thing that you can do for that, get your patient to walk and move a lot, move their shoulders, because what that's going to break down those big carbon dioxide bubbles into smaller bubbles, and it will get into the bloodstream. The patient then will either burp it out or hopefully, pass gas. And this will go away after a couple days, but some warm, moist pads will make your patient feel better. Lots of movement, lots of ambulation, getting up, walking around, and pretty much that's the end of it. This is a really low risk procedure and does wonderful things to get rid of a gallbladder that has stones in it. If it is a gallbladder that is just inflamed, we use the low-fat diet and some antibiotics, and it's usually okay. Let's talk about the pancreas. Your pancreatic enzymes, these are important to know. You've got really, really, really powerful pancreatic enzymes. Your pancreas does two things, as we know. It's got the endocrine portion, which with the aisles of Langerhorn and the insulin production, that is the endocrine part of your pancreas. The exocrine part of your pancreas is the digestive part of the pancreas. So your pancreas produces lipase, and this enzyme also helps break down the digestion of fats, similar to bile. Amylase breaks down carbohydrates when you eat your carbs. Secretin, this stimulates the pancreatic juice, so you'll get these pancreatic juices flowing. And trypsin is important for the breakdown of protein. So the exocrine part of the pancreas, sort of like the gallbladder, it will recognize when these agents, fats, carbs, and proteins, are entering the system, and it will squeeze and it will release these pancreatic enzymes through the common bile duct and again into the small intestine to start breaking down these different things that we eat. Well, here's the problem. Sometimes in pancreatitis, those very, very powerful juices that are supposed to get excreted through the common bile, or the pancreatic duct, through the common bile duct, sometimes that starts leaking and these juices ooze out and start actually eating the pancreas itself. It is extremely painful, and oftentimes it is caused by alcoholism. So people that drink a lot, not always, not in every case, some people just, get pancreatitis a lot, but it is the side effect of heavy alcohol use as well. So the problem with pancreatitis, it's a little bit hard to treat, and because one of the treatments of pancreatitis is to keep your patient NPO, because that list that I just showed you is pretty much in every food group, so you have to not have the patient eat any of those things. It's extremely painful, so we do need to treat pain. However, you have to treat it with morphine, not Demerol, because Demerol can actually induce spasms of the pancreas and biliary duct. So if you have a patient that's coming in, you suspect they may have pancreatitis, but you're not sure, and the physician writes an order for Demerol to keep them out of pain, you might want to double check and see if they can switch that to morphine, just in case it's pancreatitis because of the spasms in the pancreatic and biliary ducts. The other thing that Demerol does is the CNS, the central nervous system, does not necessarily like Demerol, and it can also lead to some central nervous system irritability and seizures. So we're a little bit more careful, cautious with Demerol. It's a little bit of the one of the older drugs. Most people don't use it anymore because of the high side effects, and because we have some other narcotics that work just as well without the major side effects. So your patient who is starting to develop pancreatitis, they have to be NPO, and sometimes they have to be NPO for weeks. And if that's the case, then they have to go to the hospital and be put on TPN. And you've got to be really careful with TPN because it can't have too much sugar in it, because then it stimulates the pancreas to produce insulin. So it gets pretty tricky. These patients can lose a ton of weight, they can become malnourished, and they're in quite a bit of pain. They also causes a lot of nausea and vomiting, so you got some fluid volume deficits. So this is a tough problem to have. So and people who have pancreatitis, they're often prone to getting pancreatitis again. So we don't really have good drugs for it. It's really just to rest that pancreas, but it's a tough one to treat. I already told you about all of this stuff. So your pancreas, you got your exocrine and your endocrine, and they can diagnose if it's pancreatitis or pancreatic malignancy with this thing called an ERCP, which I can't remember what the C and the P stand for, but I'll figure it out. There's a picture of it on chapter 50, figure 3 of the textbook. So we'll look that up. So I think I probably already mentioned what do you do if your patient has pancreatitis. Obviously we're going to keep them NPO like I already said, told you about TPN. Oh, here's a thing to remember that your patient who has gallbladder contraction, so obviously your gallbladder patients as well as your pancreatic patients, they should not have coffee because that causes stimulation of those organs, which is contraindicated in both of those things. Pancreas and gallbladder problems. High protein, again, now the thing about protein, remember, is when your patient eats protein, it's really good for muscle rebuilding, muscle growth, prevention of decubitus ulcers. You've got to have protein for good muscle buildup. The problem is the breakdown of that is, it's quite a cascade. It's the amino acids and then breaks down into uric acid and eventually ammonia, and which normally you can excrete it. Normally it's no big deal. In a functioning person, you excrete it and yippee skippy, it got the protein and the muscle use, but in patients where that's not working, it can increase the risk for hepatic encephalopathy. So you need to be careful with that. Obviously, we're not going to give high-fat foods, especially if there's also a gallbladder component. Because your patient is going to be NPO in the hospital, they're at high risk for atelectasis, fluid in the alveoli, so we're going to want to use their incentive spirometer 10 times every hour. You're going to want to reposition them often, help them to cough and deep breathe, because you don't also want to have a pneumonia on top of a pancreatitis or a cholelithiasis. Monitor their temperature and make sure, because that atelectasis can easily convert into pneumonia. Pancreatitis, like I said, is people can die from this. It is a very serious disease that can actually, take people's lives, and it can lead to shock and multiple organ failure that can occur with this. So it's a tough disease to try to manage. And then the last thing I wanted to talk about was pancreatic cancer. Pancreatic cancer is a deadly cancer. If you are taking care of somebody who's been diagnosed with a pancreatic cancer, spend some time with them, see if they want, to talk to a pastor. It is a very serious cancer. It is on the order of ovarian cancer. When you hear ovarian cancer and pancreatic cancer, those are pretty much two of the worst kinds of cancer a person can get. Not completely a death sentence, but it's very, very tough. So here's the deal with pancreatic cancer. If a patient all of a sudden starts getting jaundice, especially painless jaundice, because your gallbladder can cause you to be jaundiced, but that's painful. Pancreatitis, painful. But if it is painless jaundice, then your patient has like an ultrasound or something. They can start getting some enzymes. They might start losing weight. The physician can do an ERCP, go in and take a piece of pancreas to get the biopsy. If that tumor is in the head of the pancreas, which now is going to block that common bile duct, the bile starts backing up, your patient gets jaundice, which is usually the first sign that triggers that there's a problem. They get a piece of that, find out that it's a malignancy, then they can operate. So it is a huge blessing if the tumor, the pancreatic tumor, is in the head of the pancreas. If that patient starts getting jaundice, that's actually a much, much, much better sign than if the tumor is in the tail of the pancreas. Because if the tumor is down here in the tail of the pancreas, all of the bile that's coming through the common bile duct can still get by, and this patient will not get jaundice, and this tumor is going to continue to grow and grow and grow, and there's a lot of space for it to grow. So by the time that it's identified, typically the person usually has a very, very short amount of time to live. If they can identify it early, if it's in the head of the pancreas, there is a procedure called the Whipple procedure. And what they do is, it's extensive, it's a 5 or 6 hour surgery, but they can cut this off and then they reanastomose the tail of the pancreas, they reanastomose it back into part of the small intestine. Usually they have to follow up with chemotherapy and stuff just because of the nature of the cancer is so malignant, so aggressive. But anyways, if the patient's jaundiced, that's a much, much, much better sign. Okay, so there you go. That is the hepatic biliary system. It's actually quite complicated. I could talk about the system for days. I could go into each one of those things for a really long time. But at your level, for what you guys need, that's what you need to know. That's the hepatic biliary system. Good luck. I'll see you in class.